Dr. Mohammad. Dr. Mohammad Alreshidan, we cannot hear you. If you can hear us, please shout out.
I can hear you, but you can hear me now?
Yes, we can hear you now. Loud and clear.
Okay, thank you so much. Welcome everybody to King Salman Heart Center. We are in the operating room. I'm sorry we could not share with you the slides because you have some cybersecurity issues, but I will give you a brief about our case today. She's a 49-year-old lady. She is known for diabetes, hypertension, and dyslipidemia. She's morbidly obese. She underwent sleeve gastrectomy a year ago, and she lost 30 kilogram. After even she losing this weight, she's still her BMI is around 40. She presented with heart failure with a shortness of breath and New York Association class 2 to 3. And she had an echo which showed severe mitral regurgitation, moderate to severe tricuspid regurgitation. And as you can see here on the screen that she has atrial fibrillation and she's been treated with Abixpan, digoxin, and metoprolol. So for the sake of the time, I will start the case here. I'll show you. And then while we're arresting the heart, Dr. Khalid will review with you the echo. So we're going to go on bump, and then while we're on bump, we will explain what we're doing here. Bismillah ar-Rahman ar-Rahim. Let's go. See, let me know what's your flow.
Good afternoon, all. As we see here in the midesophageal push review, for severe mitral regurg. I'll review the image. Okay.
Can you drain better than this, please?
The light.
There is no comment about the echocardiographer from the echo.
Khalid, can you comment in the echo?
Can you hear me, Dr. Baradi?
أي نعم.
Yes. This is the echo as you see. This is the midesophageal two-chamber view.
Yeah, but I'm not happy with your drainage though.
There seems to be a kink, Muhammad, in your one of your cannulas. Yeah, one of your lines.
You're okay now? Okay, guys, can I comment here a little bit before we go to echo?
Go ahead, please.
So we cannulated here, as you can see, ascending aorta, antegrade line, and we have SVC and IVC. When you do maze, you have to really go around the SVC here, and you have to open the groove here.
Muhammad, sorry, your light is so shiny, so we cannot see the picture very well.
Okay, can you see now better?
Yeah.
It's much better now.
So you open the oblique sinus here, so and you have a full access to the atrium, and then you will be able to see the coronary sinus. So you'll be able to do the coronary sinus lesion from here.
Muhammad, can you remove the headlights, the OR headlights? Thank you.
Yes,
This is much better.
Okay, sure.
Good.
So it's the IVC. You do the SunGuard groove here, and we're going to be clamping now and arresting the heart. So this is how we set our left maze here. Sure, please. Any questions?
Just start, arrest the heart, and then did you put the clamp on? Not yet, hey?
I'm gonna do the clamp soon now.
Yeah, put the clamp and then we can ask you questions while you are giving cardioplegia.
Okay, let's then we're gonna go to echo.
Mohammed, can you tell us why it's important to dissect Sondergaard groove very well in your maze?
Sure. So, flush please, yeah. Root on. So, as you can see, Haitham here. Give me forceps, please. Forceps. As you can see here, I move SVC and I can have a full exposure for my coronary for the Sondergaard groove. So I dissected. You can see the right atrium and the left atrium, and I will be going here. So we'll have full exposure to the mitral valve.
Mohammed, Assalamu alaikum. Naeem, can I have a question?
Yeah, please go ahead.
Yeah. Is there any consensus about the approach to the procedure? So you're going to do the valve first, or you're going to do the ablation first? And there is any other protocol that can help you to maybe cardiovert the patient first and then do your line rather than doing everything with a fast heart rate? What is your approach?
Slow down. Back up on the floor. Go integrate. So that's a good question. When we do maze, we start always with maze because we're going to freeze the tissue, and then we'll tackle the valves. If you do off pump, that's a different approach. But if you do this because the patient she needs a mitral valve, then we have to do the maze first. So you guys can see here, I'm opening the left atrium now, so it's just the heart while we're arresting. And the bleed is going on, and you can see here from the ECG now. Can we switch to the ECG? That the heart start to arrest, and we have a very nice blood pressure tracing. So do you want us to go to echo and then we get questions?
Yeah, describe the echo, please, briefly.
Let's go, please.
No.
Give me sets.
Yes.
I need it.
Yes. This is the echo. This patient. This is the image we could conduct before arrest the heart. We can see here in the two-chamber view. And here the micro view.
Scissor. Give me a stitch.
Here we magnify.
Assalamu alaikum.
Salam.
Mohammed, Assalamu alaikum.
Yes.
Allah yadikum al-afiyah. Mohammed, I have few questions. So I have to say you're probably one of few surgeons that I have met who are interested in arrhythmia, and people talk about an arrhythmia surgeons. So what you, and forgive my ignorance, but is what you're doing is just is it something that a general surgeon, like a cardiac surgery fellowship or residency is enough, or you have to do specialized training? And how many from the field that you know are interested to be part of the arrhythmia management teams?
Okay, thank you. That's a good question. Look, I mean, general cardiac surgery training will give you the setup to do the case, but to be specialized in arrhythmia surgery, especially the cryothermia, you will need a special training. When you have a full understanding of the technology, how does it work, and how to get a very good outcome. In terms of do I know surgeons that they have interest? Yes, of course. You have some of the panels. I work with Dr. Hussein in his center to start this procedure. And also Dr. Haytham, he's doing MATE, but maybe he does not do what I do now. He do it with RF. And I have Dr. Firas Khalil also in تخصصي. He does some cryothermias every now and then. But in King Fahd Medical City, we are the most constant center doing this procedure. Blue one, please. Cryoablation.
Can you now, Muhammad, can you tell us what you are doing and how you expose the area, please?
Okay. So this is,
And
as
we'll
you
take
can see
any
here.
questions, please raise your hand so we will be...
So this we open the left atrium here through the SunGuard groove. We start having exposure to the atrium. Usually when I do these cases, I put an LV vent.
Take
Because,
the echo away, please. The echo is in the view, so we need to see a bigger picture.
Blue one, please.
Yes.
Blue.
Can you
So-
come closer with the camera?
Can you see my surgical view?
Yes, but we need a closer view a little bit.
Okay. So can you zoom in with my camera in here or no?
No, now it's away. Come focus. Perfect. لا لا هذه too much.
Go back a little bit. So this is the SunGuard groove. We open the left atrium and we put a pulmonary vein vent through the right superior pulmonary vein. The most important thing you can see, I can see the coronary sinus here. That's where we're going to start my ablation. So I know that I'm going to be able to do the procedure. And once I have the full exposure for the left atrium, after we arrest, I will show you. But this is the setup for the surgeon. You have to have a good exposure to the left atrium. We write the CNI in a good spot that it's away from your ablation. And we use an element away. And the most important thing in this procedure to make sure that you have a good exposure.
Tell us when you're going to start doing the ablation.
Yeah, so how much bleed? Okay, bleed is off. Okay. Root on. Give me a handhold, please.
Haytham will take you step by step with the ablation here. And after
Okay,
the
here, see,
ablation,
guys-
we can take questions.
Next, please. Right. Okay, guys, you see me now?
We see you very well. Very nice exposure now.
This is the coronary sinus, and this is the mitral area. To now start the blade toward the B3. Give me the probe, please. Test the probe. Off. Okay. Yes, decompressed. So the first lesion, you take the probe and you make it a little bit straight. As you can see my probe here. You see the probe, guys?
No. Now we can see it.
Yes. So the first lesion will be a little bit straight. So we make the probe straight like that. And then we go from the, as you can see here, from the coronary sinus, which you see. Give me ice, saline.
We have to explain to the audience that he exposed the mitral valve through the septum. So he went transseptal. He opened the right atrium, septum, and then he went transseptal.
Okay, so you see the coronary sinus now?
Yes, we see it.
So I'm on top of the coronary sinus. I'm going to be toward B3. Freeze.
This is an epicardial lesion from outside the heart.
You see now, yes. You see, guys, here I'm pointing toward B3. This is the tip of my ablation. And here you make sure that you're away from the circumflex artery, which will come in this area. Marking pen, please. So when we do that, I mark here with the marking pen. You see, this is the ice ball start to form. So when I go back and do the mitral annular lesion, I'll be in the same spot where I see my ice ball. And if you look here from up, I'm ablating already the coronary sinus.
how important, Haytham, the coronary sinus lesion? Not a lot of people doing it. It's very important, but not a lot of people doing it this way. So how important it is? Does this affect the outcomes at the end?
You asking me or ask Haytham?
Asking you.
Yeah, sure. Thank you. Well, look, if you want to have a Cook's Maze 4 procedure completely very well, you have to include the coronary sinus lesion, because that still includes sometimes 10% of the source of atrial fibrillation. So if you're aiming for a freedom from atrial fibrillation of more than like 80% or like 90%, you really have to do this lesion, including the mitral valve annulus lesion too.
How long you stay to do this now, the ablation? You are
So 3 minutes in each lesion, left side.
How many?
3 minutes.
3 minutes. And do you go by thickness also, or it doesn't make a difference?
I hope you appreciate. You see the ice ball?
It's
Yes,
not
we can
obvious,
see it,
but
Yeah, it's,
You see it here?
yes, we can see it. This system is what system is this?
This is cryo system, Dr. Adel.
Yeah, cryo, but what company?
AtriCure.
AtriCure?
Yeah. How many minutes? How many seconds? 30 seconds, okay.
Muhammad, the thickness of the atrium, does it make a difference, or you always standardize it as 3 minutes?
Usually 3 minutes is enough. Sometimes you can go less, but I don't go less. I don't like the shortcut. Sometimes you can see here it's already transmural, because I know that the tissue is freezed, but I usually go 3 minutes. 3 minutes usually is good to go.
3 minutes is what we do.
Go.
Yeah,
Go.
so,
You can.
like even like in the endocardial ablation, like when people try 2, 4, and 3 minutes, and honestly after the 2 minutes, and like you get durable lesions. So this is the same time that we use for our endocardial ablation. So regarding the thickness, Muhammad, the one area that we have difficulties with is the ridge, the Marshall region, and the carinas, especially on the left side. Do you do anything special about these areas, or it's the same protocol for every area in the heart?
Thank you for the question. Look, our surgical ablation is give me the bigger one. It's a little bit different than the transcatheter ablation, but I'll show you now. This is the left atrial appendage as described today. So the next to the appendage.
to see the appendage clearly, Muhammad, we have to be behind your head. We can't see it very well here. If you can switch to the other camera.
Switch to my head cam, please. Do you see now, guys?
The handle, we actually see the handle only. But if you can point with your debakis,
Can you switch to my? I need this cam. Okay, you see now?
Yes, can you zoom in? Is it possible to zoom in a bit?
I need suction here, please. Give me a.
So Muhammad, tell us what lesion you're doing now.
Yeah, just give me a second because I'm adjusting my angles, and I'll explain it to you. Suction, please. Don't use this. Use a sucker, please. Sucker. Up.
At this point in time, he's trying to put the.
Okay, I'll show you now what. So I'm inside the left atrial appendage. Okay, as you can see here, and this lesion going from the left lower border of the left atriotomy inside the left atrial appendage. As you can see, this lady, she has a very redundant left atrium. That's why this lesion was a little bit tricky to be able to do it 100%. But you can see the ablation line goes all the way, and it's exclusive all the way to the left atrial appendage. So that's the second line that we do in the left atrium, ablation. So I hope you can see that probe inside the left appendage.
Muhammad, can I ask about two things, please? What is your experience with the atrial trimming of the atria?
You mean atrial reduction?
Yes.
Yeah, we do that inheritedly when we close the left atrium after we finish. We reduce it by 4 centimeters because we take the left atrial tissues, we close, and you will be able to reduce the left atrial size from like this lady. She has 8 centimeters. I will be able to decrease it to 6 centimeters.
And what about the right atrium if you are doing biatrial maze?
This
Right atrial reduction.
Yeah, I will show you when you go to the right atrium. Yeah, we can also reduce the right atrial size as well.
Mohammed,
go
I
ahead,
have a
please.
question for you regarding the exposure of the mitral. Do you always go transseptal, or sometimes you open the right and left atrium?
No, when I do maze, I do biatrial incision. I don't go transseptal because if you go transseptal, the pressure is higher and exposure is difficult for maze. So that's why I do the left atriotomy and right atriotomy.
The other thing is when do you
We can
do the
discuss
ligation?
The left atrial appendage.
Yes.
Yeah, this lady will ligate it from inside. I'll show you the work technique of sewing of the left atrium. I want you to appreciate how does the ice forming into the left atrial tissue. So we're sure that this is now transmural.
Because
By this
sometimes with the maze procedure, some people like to ligate the left atrium and then they start their maze. That's the sequence.
Yeah, the sequence here, we start with the coronary sinus lesion. We do the left side, which is the first lesion. We're going to do the next left and then the coronary sinus. And then we'll do the right maze and come back and close the left atrial appendage. That's the sequence. Because you cannot close the left atrial appendage and still the tissue is frozen. You can see here the line of ablation now, and it's all like 100% transmural.
Haytham, have you experienced any issues with injuring the circumflex artery or damaging a normal mitral valve when you're doing these lesions, especially when you have the mitral valve lesion or this lesion that you just did now?
Thank you for the question, Dr. Hussein. Alhamdulillah, so far I had one injury to the left circumflex artery, but that was in the beginning of our series. Freeze, please. But mitral valve, usually the risk of it's low because we see that. Okay, so I'm going to explain to you the next lesion now. Going from the upper border of the left atrium, and we meet the other line here, as you can see here. So now, by this, you excluded all this area of the left atrium. All this is now outside of the left atrium because incision excluded. This is line, and second line is here. So practically all about the left atrium is being excluded now. Suction, please. So, drain better, please.
Mohammed. Can I ask about the? I know my knowledge is very limited, so I know pump time matters a lot for you as surgeons and even in the ICU. So on average, how long will the maze and the left atrial appendage ligation add to the pump time? And do you notice any difference when they come off pump when they go to the ICU after?
Thank you for the question, Dr. Mohammad. I mean, it adds up to 20 minutes to the clamp time, but it gives the patient survival benefit. So I don't think adding 20 minutes to the pump time will affect your surgical outcome tremendously. If you know how to do it and you have a good outcome, but adding 20 minutes with a poor outcome, that might be counterproductive. I think patients who comes out to the OR with the sinus rhythm, to the ICU, they have a better ICU stay because they become more hemodynamically stable. Here from my colleague Hussein and if you have
Mohammed, I
thought
have,
on this.
yeah, we did the last time very long cases, triple valve and double valve, and they all did very good, and the function improved, everything was good. Mohammed, I've seen you trying to keep the field dry, not to get any blood attached to the probes, just probably for the sake of getting transmurality. So now with the EP, you're working inside basically blood. So do you think this is maybe one of the factors that makes the surgical ablation more effective in restoring the sinus rhythm and long term? Or do you have any other explanation?
Well, I mean, I'm not, but I think we can hear from Dr. Naeem. I think he presented yesterday the balloon catheter. I think when they do that, they inflate the balloon and they try to isolate the pulmonary vein. So when they ablate, they have a bloodless field. But yes, for sure, when we do this surgically, as you can see here, I'm making the field dry. So I don't have blood coming to the probe, and this is make sure that the contact is good and the transmurality is better. We can hear from Dr. Naeem if you mention that.
Dr. Naeem just left because he has to catch up his flight. But as you exactly said, so what we do when we do endocardial cryo, we monitor the first thing that we do is like we try to occlude the vein completely. And when we occlude the vein completely, we know that like we have a complete contact. We can use contrast, we can use pressure measurements, and also we can use intracardiac echo. And then the other marker that we look at, we measure the temperature drop. And if you have a decent temperature drop, it means that we are cooling the tissue pretty well, and there is not a lot of blood flowing around the balloon. That will tell us that we have good contact and good seal. So we do more or less the same. And I think if the limitation of our endocardial approach, honestly, is transmurality. Because what you're doing here, like there is no doubt that you have a transmural lesion. You are ablating from outside, and you see the endocardial component, especially with the back wall. I think that if there is an Achilles heel with our endocardial methods, is the assuring transmurality without causing collateral damage.
Okay, that's the last left side lesion here. I'm ablating now into the mitral valve annulus, and as you can see here, I'm on top of my the blue line when I did before. So this is the mirror image lesion of the coronary sinus, and this is to prevent, as I said in the talk today, the atypical left atrial flutter, because this is very intolerable for the patients.
Dr. Mohammad,
do you
what about
encircle the pulmonary veins with the cryo, or you don't?
Pulmonary veins?
Yeah.
What's the question?
Yeah.
That's the pulmonary veins.
Yes.
We don't touch them with the cryo. We are on top of them.
Yes, but you don't, just like the edge of the pulmonary vein, you don't cryo in those edges, like encircling them, or no?
We encircle them, but we don't go to the ostium of the pulmonary vein. So the risk of pulmonary vein stenosis is very low in this procedure.
Yeah.
Dr. Mohammad,
There's a question, تفضل.
yeah, what about the rates of AV blocks, including complete heart block, with or without valve replacements?
Look, I tell you that in literature, they said it's between 5 to 8%. But in our series, we have 80 cases. And alhamdulillah, we have only one patient with pacemaker. I think this all depends on the landmark and the way you conduct your procedure.
That's amazing.
While you are doing this, can you tell us your post-op protocol regarding the anti-arrhythmic, just briefly, Mohammed?
Thank you for the question. We do amiodarone. We give 150 IV bolus in the operating room, and then we keep them in amiodarone drip for the first 24 hours. And then we switch them to oral amiodarone for 3 months. Depends on sinus node reaction after surgery. But usually we keep them in 400 BID for a month, then 200 BID for a month, and then 200 daily. And then we stop it after 3 months and we switch to beta blocker. Some patients, if they still have tachyarrhythmias with amiodarone, we add beta blocker to them if they tolerate that too. Okay.
Any questions from the audience? Haitham, do you have any comments since you are active in this?
I just have a comment about a question that Dr. Naeem asked. Do you do the mitral first or do you do the maze first? And we should always do the maze first. The reason is the mitral isthmus lesion. You really have to go all the way to the mitral annulus. And if you put your valve before creating this lesion, you set yourself up for post-operative atrial flutter.
Yeah, can you see here, Haitham? I'm in the mitral annulus. You see that?
Yes. So this is the mitral isthmus lesion. It has to go all the way. It has to touch the mitral annulus. And if you do the valve before the maze, you cannot accomplish this lesion very well.
Okay. I'm going now to do the right maze. So when you do right maze, we do a right atrial incision, but this is close to the IVC. Hold this, please. Can you see what I'm doing now?
Yes, you're holding the edges of the right atrium and the right atrial appendage.
Yes.
Yeah.
Give me the knife, please. So I do a longitudinal incision here, and I don't snare the cables because I don't want to have because I want to access VC and IVC. And I go down there. You see, that's enough incision for me to do the procedure for. But this lady, I might do tricuspid valve, so I might be able to extend this later on. So the first lesion we do, as described in the presentation today, go integrate. I'm giving blegia now where I'm doing this, as you can see. Can you see my camera?
We can.
Okay, so this is the first lesion.
Can
I go
you
from
focus?
the right atrium to the.
Come closer with the camera, please.
Okay. Freeze now.
Yes, now it's good.
Okay, relax, you know. So here you see the tricuspid valve between anterior and posterior. And while I'm doing this, I'm giving blegia into the right atrium, into the aorta. So I prevent any injuries to the RCA. So this is the first right-sided lesion that we do all the time. And I do that for from 1 to 2 minutes. We're gonna do it. We're gonna set the machine for 2 minutes, and we'll see if this is gonna be transmural enough. Any questions?
Any questions from the audience? Adel, do you have any comments?
Well, I was just asked a question by Dr. Fahd Al-Mahmadi. Is this elite surgery or this is regular day-to-day surgery? Any surgeon can do it. Maybe Abdulaziz, you can answer this.
Actually, listen, you know, like I can comment on this. You know, like you have to have some training, and now in the new era of cardiac surgeons, they have this. In my days, we went to courses. We brought the machines and everything, and we started the procedure. Also, you have to know that cryoablation and ablation started almost 20 years ago. Before that, people used to do maize as cut and sew. So they used to cut those, the left atrium, everything, like they demolished the heart. And then they sew it back again, and then they do the ablation. With the new technique of the ablation, we learned it from courses and some workshops, and we went and do this. Now in this era of cardiac surgery, people like to come to centers, learn, do some workshops. I don't think that you need really a special training for this. Like you go for 6 months or 1 year to be a maze surgeon. I don't think this is
understood.
happening.
Now this
but
lesion
this
is the
procedure can be done for the people who are really interested in this.
Let me interrupt you here. So this is the SVC lesion. We go from the lower border of the right atrial to the lateral border of the SVC. Here you have to be careful because SA node somewhere here, you know. So I know that my line is very far from the SA node. So having SA node dysfunction is very low. And as you can see here, this is freezed already. So I know that this is a transmural, and we are only 30 seconds. So and this lesion I might only go for 1 minute. You can stop. How many you give?
Can we see the machine, how things go? Just a video with the machine to see, so people can know how how things on the other side.
You can stop. You can see the machine in my camera now, head cam?
No.
أرفع شوية.
Yes.
You see that the time is there. So this is the time, and this is we start at 2 minutes, and now at 40 minutes. And this is the temperature. You see that minus 66.
Okay, so you rely on the temperature or time only, or both?
No, I look for both. Usually with this machine, the maximum you can go minus 69, minus 70. And the time is, as you can see here, I set it at 2 minutes. You can stop.
I think just going back to the comment of Dr. Abdulaziz Al-Baradei, one thing I want to add is the problem with the cut and saw, the reproducibility had a lot of complications. So very expert people can do it well, and then average surgeons or other surgeons, it's not reproducible, it doesn't become widespread. I think what you're doing here is elite, but it looks reproducible. It looks like we can teach it to surgeons easily, and you told me that you went to centers and you taught surgeons how to do it, and now they're doing it and doing cases.
Yes, that's the lesion, we call it right atrial lesion. We go from the upper border of the right atrium to the right atrial appendage, and as you can see here, it's already the transmural.
Mohammed,
yes, go ahead.
You mentioned about the timing. Do you do 3 minutes on the left atrium and 2 minutes on the right atrium, for example, or what's your protocol?
Yes. That's the usual, but today because the right atrium is thin, 1 minute, 1 minute and a half is enough because it's already the tissue. You could tell.
But usually for the right side, you do less timing, right?
Right is always less, yes.
Yes. Okay. Going back to the atrial ablation and all this, there is, like I have to say also, I am in favor of to have a patient who is in sinus rhythm. But some people, they say controlled AF. And controlled AF has the same survival, have the same this, all this. So there is lots of debates. So that's why I said that you need interested surgeons to do this, because not many surgeons believe that putting a patient in sinus rhythm is better. But I have to say, I always answer them like God created sinus rhythm. He did not create controlled AF. So we should put it in the way how God created us, you know? So that's how things can, in my opinion, but some people don't believe in ablation or atrial fibrillation or other things. Yahya, he's looking at me. Maybe he has a comment here.
As you said, factory setting is the best, and we always aim for sinus rhythm. And it's no longer arguable that sinus rhythm is much better than what you call controlled AFib. So the aim in every and each patient is to maintain sinus rhythm and restore sinus rhythm, except in very, very few patients who are you try with them, or because their comorbidity, their age, they are bed bound. Otherwise, any patient, I think, deserves to be in sinus rhythm like he was made by God. It's amazing to see this ablation procedure. I do understand that when you have somebody who's going for mitral surgery, and we should always do that. I think in many centers it is the standard. If patient is going for mitral surgery and he has atrial fibrillation, he should come out of the surgery with MACE. The adoption of the solo surgical MACE is, however, much lower. So I want to hear the comment of Dr. Alreshidan or our colleagues here about the adoption of solo surgical MACE, which patient should be considered for standalone surgical AFib ablation.
So I just want to give the last comment. This is the last lesion on the right side. We go from the left border to the IBC lateral wall, and we freeze this, and you can see it's already freezing. So that's the sign we see an IBC. Stop. So for solo maze, I trained in a place where we do solo maze all the time. But again, solo maze, this is not only surgery. I think this goes into a team. We have to have an atrial fibrillation team that believes in providing the patient with the best evidence practice. So if you have a patient who have it and they fail their medical therapy and they fail their transcatheter, I think they should go for surgery. So this is the left atrial appendage. I'm going to show you how we close that. So as you can see here,
before you start closing it, can you tell us the lesion itself? How does it feel in consistency? You know, because it looks like it's hard.
Well, look, this patient is hard. I have to tell you, it's not the straightforward case, but I think it has to be systematized. If you make it systematic, you will have a good outcome. I have a stitch, please, for all.
Yeah, this is now the left atrial appendage, right?
Yes, I'm going to show you quickly how we close that, and then we can conclude here. So this is how you do that. So we go to the base of the appendage, and I do that in double layer. So I try to not to go deep in this area because was mentioned by our LCX issue here, you know. Hold this, please. Give me a shot.
This is the inferior part, right?
Yes, I'm going superior. I agree. Yes. So here you can see when you do that, we take the body of the left atrial appendage with us. Going to this side or the free wall of the left atrium, I'm not concerned because the circ is there. If you go here, you go, but here you can go deep. And that's what should compensate for you the risk of left atrial, the recurrence rate. So as you can see here, I take the trabeculation of the left atrium with me. So the risk of recannulation is very low.
Mohammed, have you ever used the clips, the AtriCure clip before?
I have them in the shelf. I use, but today for the sake to show people how to close this surgically.
And I think now Medtronic, it's not here yet in the market, but I think they have a new clip as well.
Yes, I was with Medtronic on a conference, and I was part clip. I give my recommendation. They're gonna have a very good clip coming to them.
Mohammed, I'm asking you all of the questions that we come to our mind when we do the endocardial cryoablation. So you can see the crystal ball forming on the tip of your probe. Is there any risk of avulsion or laceration when you take it off?
You mean injury to the left atrial wall?
Yes, because for us, for ablation, we have to wait for things to warm up, and then the balloon will deflate on itself so we can move it. But like here,
here we have the defrosting mechanism. When the probe defrosts and the temperature goes to 0, and then we remove the probe up, you know?
Yeah,
and then the tissue has blood, so we will tissue defrost by its own. That's why we have to do the right maze before the left maze, before the left atrial appendage, because I want to make sure I have unfreeze tissues so that I can close them.
Mohammed, for the appendage, why not chop it off from the outside?
That's a good thought. We can do that, but you know, I don't like to do that. I trained with, and we do closing it from inside.
Okay.
But yes.
And in some elderly ladies, sometimes their tissue is friable from the outside, and you might have some bleeding as well.
I prefer just to keep everything inside, and risk of bleeding is less for sure.
I do usually. I usually chop it off from outside, but I use a cuff. I leave a cuff of tissue that I can. I make sure that I have something to saw to without going deep, and because the circ is very close there. It's not even, isn't it?
Actually, the most reliable way of closing the atrial appendage is from amputating it from outside. That ensures that no space remains, actually. It's the most reliable way. This, as Mohammed mentioned before, has a risk of recanalization, but doing a double layer closure assures that the appendage does not recanalize.
And chopping it off from outside, there is no risk of recanalization. It's just amputated.
You know, like I have to say that amputating it is a very good way, but you know, like it's really associated with many complications, especially bleeding. Sometimes you end up with a bleeding that you need to control very well, and you put yourself in a place which you don't want to be. Especially in our population. Our population have extremely friable tissues. They come with extremely dilated LV. I believe that with the 2-layer, this procedure is safer, and sometimes you have recanalization, but it's not that, you know, like, and always there is a debate, even in our meetings, regarding amputation, clipping, sewing from inside. Myself, I usually do this 2-layer. The first layer, I do it as horizontal mattress to be used. And then the second layer will be more thicker, and I do it running.
Right. Guys, this is how does it look finally. It's all closed here, a double layer. This is the left superior, left inferior. This is right superior, right inferior. Thank you so much for being with us today.
Thank you, Mohammed. That was very informative.
You. Just can you stay a little bit, just if we have any other questions from the audience before we let you go?
Switch my headlight. Switch my headlight.
Just
I'm going to stop my trial till you guys ask questions. Okay, go.
Anyway. And then we'll let you go.
Yeah, it's okay. It's up to you.
We have one question.
Mohammed, this is Wael. Great case. Can I ask you, how do you manage early recurrence of AF? Because in the catheter ablation, we believe that early recurrence not always predict late recurrence because of edema. I don't know if this is the same pathophysiology with your lesion sets.
Thank you. That's actually, you are absolutely right. I treat them like catheter ablation. That's why we keep them on. And if they come back, I actually cardiovert them. And if we have, after cardiovergence, most of them, they goes back into sinus. But if we have issues with that, then I send for EP for a possible catheter for EP study. And if there is any skip lesion, then we can treat them. But alhamdulillah, I have not countered that, but that's part of the management.
Any other questions, comments from Haytham and Dr. Hussein?
I'd like to thank you so much, Dr. Mohammed, for this beautiful case. And if there is any question, just probably close.
Okay, thank you very much. This will conclude our transmission. Thank you, Mohammed. Thanks for all the team in King Fahd Medical City. We need a follow-up on this, but you can send it later on and show us that the patient is in sinus rhythm, okay? Thank you.
Yeah, I'll send you the rhythm to the group, and you can share it with the audience, inshallah.
Thank you.
Okay, bye-bye.